Hereby, I open this academic ceremony in which Elena Caporali will defend the academic thesis, Assessment of Different Interventional Treatments of Aortic Valve Disease. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. Distinguished Prorector, distinguished member of the Corona, dear colleagues, dear friends, dear family, I will explain my research. Aortic valve is one of the 4 heart valves called semilunar due to its shape. It's located at the passage between the left ventricle of the heart and the aorta vessel. Heart valve disease involving nothing valve is the most common cardiovascular disease with increasing incidence in industrialized nations. And the use of echocardiography is very important in order to grading the severity of valvulopathy and staging the extent of the extracardiac damage. Aortic valve caps may undergo a process of degeneration, mainly related to calcium deposition, thereby reducing its opening and function. And the use of non-invasive imaging is very important in order to degree of the valve regurgitation and the aortic valve stenosis. In particular, aortic valve stenosis is one of the most common heart disease with incidence of 5% in population aged 75 years. And the early recognition and management of aortic valve stenosis are very important because untreated severe diseases result in poor outcomes if managed with conservative treatment. And the final decision about the treatment, the type of intervention, is based on aortic valve stenosis management, require an exal diagnosis, non-invasive imaging and quantification, possible catheterization or coronary angiography, appropriate time of intervention. And the final decision, the time of intervention, is primarily based on assessment of disease severity, presence on symptoms related to valvulopathy, left ventricular systolic dysfunction, and enlargement. And with the increasing of the age of the population, increasing comorbidities had led to development to procedure in order to minimize surgical risk and reduce operating time. And the aim of the thesis is to analyze aortic valve disease and its treatment option in nowadays, surgical and percutaneous, in a critical and timely manner. In particular, we will focus on the various types of biprostheses available for clinical use by analyzing their design, hemodynamics performance, technique of implant, and ease of use. And this was achieved through original research and complex clinical case description. Transcatheter aortic valve implantation is a valid therapeutic option in high-risk patients. And we start with the discussion of the 2 challenging cases underwent treatment in our hospital. The first of these is a TPA aortic dissection in 81 years old lady, successfully underwent aortic valve suspension and ascending aortic replacement with vascular darkroom graft. But a month later, the patient was readmitted with congestive heart failure, and transthoracic echocardiography showed a severe aortic regurgitation due to Valsalva synovial dissection and non-coronary Coop's leaflet prolapse, also confirmed to computed tomography scan. In this case, we decided to perform a transcatheter aortic valve implantation with transfemoral arches with core valve and concomitant ECMO support. The second case was about a 75-year-old man presented with congestive heart failure, severe dyspnea, with aortic regurgitation and a clinical history of kidney failure, peripheral vascular disease, impaired left ventricular function, and previous coronary surgery. In this case, their team decided for a transcatheter aortic valve implantation through left carotid artery with core valve, successfully followed by a valve-in-valve procedure with sapien valve. 2 examples of successful TAVI procedure in high-risk patients for conventional surgery. For many years, a lot of stented biprostheses can be available for clinical use and can be merged into 2 groups, the porcine tissue valve and the bovine pericardial tissue valve. Differences in hemodynamics performance and long-term durability are still today under debate, but few papers directly compare this technology. In our hospital, we decided to retrospectively collect and analyze in hospital and mid-term results of all-comer patients undergoing aortic valve replacement with a pericardial or porcine valve. And we confirm favorable clinical outcome of both these bioprostheses for isolated or combined intervention, elected and urgent procedure, but about bovine pericardial tissue valve, despite better hemodynamics performance, these prostheses showed no difference in long-term outcome. Recently, a new generation of prostheses called rapid deployment aortic valve prostheses can be developed in order to reduce operating time. And the intuitive valve features excellent hemodynamics performance together with innovative implanting system consisting of balloon expanding stent placed below the segment reel level for anchoring into the annulus. But when we use this kind of bioprosthesis, paravalvular leak may be addressed at the time of intervention in order to avoid need earlier intervention. Another problem with this bioprosthesis is a higher incidence of new pacemaker implantation. In our hospital, we decided to perform a new technique called aortic annulus stabilization technique, consisting in a surgical stabilization of the aortic annulus performed at the same time of the surgical aorta valve replacement, and this is the first report on the clinical use of this technique, preventing postoperative paravalvular leak through a better match between the annulus itself and the stent of the rapid deployment valve. In our findings, this new technique prevents postoperative paravalvular leak after intuitive valve implantation up to 1 year follow-up. For many years, several papers demonstrated that sutureless prostheses reduce operating time, in particular reducing cross-clamping time and cardiopulmonary bypass time, facilitating both minimally invasive and traditional cardiac surgery. But no randomized controlled trial have directly compared this technology with the traditional stented bioprosthesis. The PERSIST aortic valve replacement international studies were published with the overall 1-year result. It demonstrated no difference between sutureless and isolated stented bioprosthesis in isolated and combined surgical intervention in terms of outcome and hemodynamics performance. And we decided to perform a sub-analysis of these controlled randomized trials through an independent echo core lab with analysis of 2 matched populations underwent isolated aortic valve replacement with the same valve size with sutureless and stented bioprosthesis. In our study, we demonstrated that sutureless valve showed non-inferiority to standard stented bioprosthesis for measured cardiovascular and cerebral events at 1 year. Sutureless prostheses provide equivalent paravalvular leak and central regurgitation rate compared to sutureless valve, suggesting an optimal saline at the annulus. And finally, we have a similar hemodynamics performance at 1 year follow-up of the sutureless prosthesis compared with standard aortic valve. And we decided to analyze the surgical approach, both in minimally or traditional cardiac surgery. And in our study, we make a comparison in hospital, a 1-year result of sutureless versus conventional stented bioprosthesis in isolated surgical aortic valve replacement in minimally invasive and standard surgical approaches. Our patient demonstrated no difference in preoperative profile. Sutureless prosthesis reduced hospitalization in mini-sternotomy approach group and procedural time in both surgical approaches in terms of cardiopulmonary bypass time and cross-clamping time. Our final demonstration was about that sutureless valve, together with a minimally invasive cardiac approach, demonstrated better 1-year outcome in terms of cumulative incidence of major adverse cardiac events, stroke, new onset atrial fibrillation, and hospitalization rate, but at the same time, higher rate of permanent pacemaker implantation compared to patients with conventional bioprosthesis. We already spoke about the transcatheter aortic valve implantation as a valid therapeutic option in high surgical risk patients. but today it's still not clear if the concomitant presence of tricuspid regurgitation can be negatively affect this kind of population, as a tricuspid concomitant repair can be considered. And we decided in our hospital to retrospectively collect and analyze clinical results of patients undergoing transcatheter aortic valve implantation with or without concomitant high-degree tricuspid valve regurgitation. And the primary endpoints was mortality at 1 month and mortality at 1 year, and the secondary endpoints was hospitalization rate, degree of the tricuspid regurgitation at postoperative follow-up, and 1 year tricuspid evaluation. And unexpectedly, patients undergoing transcatheter aortic valve implantation showed similar 30-day and 1 year outcomes and hospitalization rate, regardless of the degree of concomitant tricuspid regurgitation. This was a very encouraging result because the two populations showed an important difference in clinical presentation and hemodynamics findings, in particular, worse NIA functional class, higher Euroscore, a higher rate of incidence of pulmonary hypertension and impaired right ventricular function. And about the hemodynamics findings, we demonstrated significant changes of a transcatheter aortic valve implantation at 1 year follow-up, improved left ventricular ejection fraction, reduced left ventricular mass, reduced pulmonary hypertension, and improved NIA functional class. In our study, we demonstrated no negative impact of tricuspid valve regurgitation on clinical long-term outcome of patients undergoing transcatheter aortic valve implantation, suggesting a positive effect of the TAVI procedure. My final conclusion are transcatheter aortic valve implantation provides a reliable option for patients with aortic stenosis, particularly for high-risk patients. Contrary available bioprosthesis or porcine or bovine pericardial tissue for surgical aortic valve replacement present favorable long-term outcome. Sutural bioprosthesis have shown similar postoperative hemodynamic results than conventional prosthesis at short term. Sutureless valve with minimal invasive surgery apparently better than conventional bioprosthesis due to reduced short-term postoperative adverse event, but a higher rate or permanent pacemaker implantation. The adjunctive stabilized implant technique reduced the rate of postoperative paravalvular leak in rapid deployment aortic valve implantation. And finally, the presence of significant tricuspid valve regurgitation in patients undergoing transcatheter aortic valve implantation does not impact short-term outcome. Thank you for your attention, and the word returned to distinguished prorector.
Thank you for your clear presentation. The opposition will be started by Professor Gelsomino, Professor of Cardiac Surgery at the University of Maastricht.
Thank you, Prorector. Dear candidate, I would like first of all to congratulate with you and your co-promoter for your very interesting work. The thesis, I think, gives very interesting insights into the all kind of interventional for aortic disease. I have two questions for you, and the first is just about, you know that several studies reported the reduction in platelets count after sutureless aortic AVR. I would like to ask the opinion of the candidate on this point.
Distinguished opponent, thank you for this interesting question. I completely agree with you because several papers describe this problem with sutureless, but also with all kinds of bioprosthesis after surgical aortic valve replacement. It's not clear the final reason of this problem, but seems to be related to the stent itself in the case of sutureless prosthesis and related to homocysteine acid used in order to reduce the calcification of this kind of bioprosthesis. Recently, Osler and co-worker published an interesting results about the comparison between 3 kinds of biprosthesis and isolated surgical aortic valve replacement, sutureless, intuitive, and sapien valve. And they demonstrated that in the 3 population, we have the same problem, the reduction, the transient reduction, the platelet count, but at the moment of the discharge, in case of intuitive and the sapien valve, we have complete recovery of the platelet count. Not the same in the case of sutureless. But the interesting findings that at 1 month evaluation, we have no difference in terms of for mortality, retrototomy for bleeding, or other problem for the patient blood transfusion, for example. So I think it's a very interesting topic for the future. Recently, we published with other co-workers a paper in which we confirmed the relation between the stroke and the isolated surgical aortic valve replacement with a rapid deployment prosthesis. But I think that most important thing was that in this patient we had no critical outcome in terms of quality of life and bleeding. So I think a topic for the future, but in this moment, only an important thing in the post-operative evaluation of the patient.
Okay, going to the second question, it's about pacemaker implantation. There's very important problems for TAVI, sutureless, and also rapid deployment valves. My question is, what is the right in your opinion, the correct post-operative indication and decision for this?
Thank you, distinguished opponent. I think this interesting question and raise the attention to this good point, because I think in this moment the problem is the lack of exact guidelines in order to make a prudent decision on the time of new pacemaker implantation after this type of intervention. We know that after isolated surgical aortic valve replacement with stenting prosthesis, we have 2 or 4% of incidence in new pacemaker implantation. Other part with transcatheter aortic valve implantation, we have a 7–10% of incidence, and after sutureless and rapid deployment aortic valve is 12 or 15% of incidence. I think it's related with the calcification of the annulus performed at the time of the surgical aortic valve replacement, but also related to the stent of the biprosthesis in the case of the sutureless or rapid deployment stent prosthesis that applies against the membranous septum, perform a damage of the conduction system. I think that very important the description in several papers like Schlomiker and co-workers that in the first year after the surgery we have the higher incidence of left bundle branch block of new onset but no new rates in hospitalization or mortality for the patient. So I think it's very important to analyze the type of patient and the clinical history of the patient, because we know that in patients with a clinical history of paroxysmal atrial fibrillation or bradyarrhythmias or other conduction disorder previous surgery, is very important the new pacemaker implantation the first 1 month during the follow-up. But if we have a patient that don't have a clinical problem, the symptoms related to this electrocardiographic findings, it's no mandatory the new pacemaker implantation. So I think the most important topic is perform guidelines in order to have a good period for a good prudent decision making on this patient. And I think the first month after surgery is a good time for this decision, in my opinion.
Okay, thank you. I give back the word to the corrector.
Thank you. The opposition will be continued by Professor Prinsen, Professor of Physiology at University of Maastricht.
candidates. I would like to continue a little bit about the issue conduction abnormalities. I hope there's not too much echo on the line here. For example, in chapter 8, you showed that this is where you did TAVR implantations, that you have over the entire group 23% new pacemaker implants. We also know that if it's similar, those kind of numbers for pacemaker implants, there will be a similar number of patients with left bundle branch block. And we know that mortality is increased by 50% by either new pacemaker implants and left bundle branch block. So this has a significant effect on the patient and also on the clinical requirements following your procedure to implant a pacemaker. So what is your view? What is your experience with left bundle branch block in this category? And what is your view about how we can improve the TAVR procedures in the future?
Distinguished opponent, thank you for this challenging question. I think the most important was strictly follow-up of this patient, because we know that the first months after surgery is very risky period for the patient. I think the good knowledge of the patient we allowed to know when the new onset left bundle branch block or bradyarrhythmias can be important in this kind of patient. But at the same time, I think the good knowledge of the intervention itself, the surgical technical use for this kind of patient can be important to evaluate for the final decision of new pacemaker implantation. I think the most important findings related to non-invasive imaging, because a good knowledge of the anatomical and functional description of the aortic valve and the annulus is very important to know the perfect shape of the annulus on the membrane septum position related to conduction system in order to avoid damage against the bundle of his and this very important conduction system for the patient. So I think anatomical functional knowledge of the patient and at the same time therapies before surgery, because field paper described a reduction and new pacemaker implantation when we stopped the beta blockers or other therapies before surgery, and surely an important follow-up time 1 month and 1 year and 6 months after surgery itself. And the same for the transcatheter aortic valve implantation, in which we have a problem with the stent position.
Yeah, I agree. And this pre-procedure imaging of the aortic valve and the membrane septum may show that in some cases the aortic valve is too close to the membrane septum, and that may lead to avoidance of TAVR. And I think that's one of the solutions indeed. Let me ask you another question about this chapter 8. You studied there a difference in outcome between patients with and without tricuspid regurgitation. What is your idea about the potential influence of TAVR procedure on the tricuspid regurgitation? Did you expect any effect? Because you're looking at the right ventricle. And so what benefit could the right ventricle have from treating the left ventricle?
Distinguished opponent, thank you for this interesting question. We have an idea of this relation between tricuspid regurgitation in patients with aortic valve stenosis, because we have field patient with tricuspid and mitral regurgitation before the transcatheter aortic valve implantation. But several papers demonstrated a relation between mitral valve and the aortic valve, but not the same for tricuspid regurgitation. We start our study with the idea that a concomitant tricuspid regurgitation with aortic valve stenosis can be considered for a future TAVI together with a tricuspid repair. But in our study we demonstrated other findings, because we show that with the TAVI procedure, with the reduction of the transvalvular gradient in aortic position, we have benefits on the pulmonary hypertension, and so in the 1 year follow-up we performed the transthoracic echocardiography with a good result in terms for right ventricle mass, right ventricle ejection fraction, and volume of outflow. So I think it's very positive effect of transcatheter aortic valve implantation, even in the hypertension pulmonary related to the tricuspid regurgitation. And I think in this patient, the good important point was the quality of life after TAVI procedure is surely better respect to the previous implantation valve.
Okay, thank you very much. I'm satisfied with the answers, and I'd like to give back the word to the prorector. Thank you.
Thank you. The opposition will be continued by Professor Boeken, Professor of Cardiac Surgery, Universitätsklinikum in Düsseldorf.
Dear Prorector, thank you. Dear candidate, here on the left side. First of all, many thanks from my side for this great presentation and for the thesis, as it addressed all points that are relevant for us also, that I find back my whole day in this book. And nevertheless, I have some questions, I hope not too complicated. First of all, the patient in chapter 2 with the redissection. And you implanted a TAVI, and you used additional VA ECMO to prevent valve displacement during deployment. I understand the physiological theory of that, but we don't do this. Is it usual in your department, or is it only this case where you use ECMO for preventing, just for preventing? You were able to win it easily, I read it, but this technique is new for me. Could you comment on this?
Distinguished opponent, thank you for this question. No, this is for this particular case, because this patient, we have a 45% Euro score before intervention. So we perform a long heart team discussion for this patient, because it's very frailty and women with a lot of problems. So we have related to the in our opinion, the most important risk was related for heart rupture, because we have a month after the previous surgery. So we decided to have the ECMO in OP, with the ECMO playing in a femoral arches, in order to avoid a bleeding problem. But for this case, not usually women perform the ECMO during the TAVI procedure.
So it was due to many risk factors, not only to prevent. Okay. Secondly, again, this topic of aortic insufficiency, using of TAVI in pure regurgitation. In the chapter 3, you describe a use of a core valve in this patient with a carotid approach.
Carotid, yes.
And you correctly state that the only valve that is allowed to use that is a Jena valve normally. But you use the core valve. Perhaps could you comment on this again, and perhaps give an overview about your experience with TAVI procedures in patients with pure regurgitation? Which did you use, and what is your experience?
Distinguished opponent, thank you. I completely agree with you because usually for poor aortic regurgitation we use a Jena valve, but in this case we decide to use core valve in reason of high profile stent of this prosthesis, because this patient present a lot of problems for intervention, in particular the kidney failure, the dialysis, and so we have a great problem with peripheral hatches, and so we decide to we have an ECMO in standby in subclavian and femoral vessel in order to avoid problem, because this patient have 10 or 15% of ejection fraction, and the problem was related to the previous coronary surgery history with a patent mammaria graft. So we decided carotid access for this problem, and we hope that the high profile of a core valve can be avoid the absence of calcification in the annulus of the valve. But we make two attempts to release the prosthesis, and then we have a leak, medium paravalvular leaks, so we decide from the same HS carotid side to perform a valve-in-valve procedure with a sapien, but we know it's a risky procedure because from the carotid HS usually have feel incidence of stroke, so we perform very different of the usually intervention.
Okay. And I think a last question, as you described very well, the advantage of use of rapid deployment of sutureless valves combined with minimally invasive approach. Perhaps I did not read it, my fault, but could you comment on the different techniques of minimally invasive approach, as there are at least two that we use to get to the aortic valve? Which do you use, and do you see differences between the partial sternotomy and the thoracotomy?
Yes. In our hospital, we perform usually mini sternotomy because chef don't very like the thoracotomy HS. And so this, my report about the first new technique, we use mini sternotomy or full sternotomy. But I think mini sternotomy is too easy to perform the surgical aortic valve replacement because of the view of the aortic valve itself. But I think a good idea perform a TG scan of the chest of the patient in order to perform a more prudent decision of the type of minimal invasive approach.
Okay, thank you for your great answers, and I would like to give back to the prorector.
Thank you. The opposition will be continued by Professor Cassina, Professor of Anesthesia and Intensive Care at the Istituto Cardiocentro Ticino.
Thank you very much, Prorector, for the award, and thank you, Elena, for the well-done presentation. And I have a general question. And how do you imagine the additional knowledge and competencies and skill needed for the new generation of surgeons that they have to deal with this new technology as transcatheter valve or aortic valve replacement?
Thank you for this question. I think despite the valve-in-valve transcatheter therapies, longer study durability of the new prosthesis can demonstrate the brilliant, excellent hemodynamics, performance, and good outcome. And these findings suggest a lower limit of age for surgical aortic valve replacement with bioprosthesis. Nowadays, we use usually bioprosthesis for patients with contraindication or for lifelong anticoagulation, and usually for patients aged over 65 years. But I think sutureless, in particular rapid deployment aortic valve, demonstrated a good result in terms of mortality, morbidity, and hemodynamics performance. So I think the most important point was the knowledge of the patient, because I think the transcatheter therapies was an effort for the treatment of the complex clinical case we daily discussed it among our team. But the most important choice in the case of surgical septal risk score remain the gold standard, the surgical aortic valve replacement in minimally or standard surgical approach. But I think the new bioprosthesis very easily, in fact, encouraging for the use of long-term surgery for the aortic valve replacement itself.
Thank you very much for the answer. I have an additional question. Do you mention the transcarotid access? This is a quite innovative approach with advantage and side effects. How do you screen the patients for this approach?
Distinguished opponent, thank you. I think in the case we perform in our hospital through this carotid access, the most important thing is the evaluation of the previous history, clinical history. In the case of previous bypass, cardiopulmonary bypass or patent graft in mammary artery, it's very important to avoid the subclavian access, and transfemoral too is not too easy. The most important thing is the good evaluation of the vessel of the patient, in particular with a good angio-TC of the neck and the chest. And we have the knowledge of the history about neurological disorders or problems related to carotid stenosis, or good knowledge of the arch and the subclavian and the carotid, the two carotid, and so the intrawillis circle evaluation. If good, I think it's a safely and very fast procedure, but it's very important the surgical isolation of the vessel and in very choice of the material, because the type of prosthesis itself or the transcatheter implantation is very important, because core valve is high profile. But the Sapiens too have an important stent for the anchoring into the annulus. So in patient older and with a lot of comorbidities, it's very important to evaluation the patient for the global situation.
Thank you very much. For me, I don't have additional questions.
Okay, thank you. The opposition will be continued by Professor Di Mauro, Professor of Cardiothoracic Surgery in Maastricht.
Thank you, Prorector. Dear opponent, first of all, let me thank you for this great presentation. I would like to congratulate you and for your thesis. I have just a question. I start with one. In the era of TAVI, which is on you the real place for IVR with sutureless or rapid deployment?
Opponent, thank you for your interesting question. I think this new generation bioprosthesis is very useful for patient, for example, with a small aortic root, because of subannulus fixation of this new prosthesis demonstrated optimal hemodynamics performance after surgical aortic valve replacement in order to reduce the reshape of the left ventricle outtract flow. But at the same time, I think that this kind of bioprosthesis is very important for the minimal invasive surgery, because the use of a sutureless prosthesis together with a minimal invasive approach, as we already spoke, reduced operating time. And reducing cardiopulmonary bypass time, aortic cross clamping time, and operating time for the global time of the intervention can be allowed a reduction of day hospitalization and consequence reduction infections, kidney failure, and risk of neurological disorder. So I think it's very important this new bioprosthesis together with a minimal invasive approach is the answer for the future in the complex patients.
Okay, thanks for your reply. And I have an additional question. On chapter 7, you report the results of a randomized clinical trial comparing stented versus sutureless. And I saw that there is a difference regarding 1 year rate of hospital readmission in the mini thoracotomy, but not in a sternotomy group. As do you explain this difference between these two subsets of patients?
Distinguished opponent, I completely agree with you. I think that the differences between these two findings in the two surgical approach and full sternotomy or minimal sternotomy is related to the presentation of the patient in hospital, in particular in emergent procedure. The surgeon choice was usually for a full sternotomy in order to make a good performance and in a traditional manner in the situation of emergent procedure. And the other findings interesting is related, I think, of the clinical history, so the sample patient analyzed, because in our population underwent surgical aortic valve replacement with mini sternotomy approach, we have a high incidence of gender female, obesity, hypertension, and so we know it's related with cause related to hospitalization, similar to we find in our study, because the cause of hospitalization this patient was pulmonary problems, blood disorders, neurological disorders, or problem about the chest site. And in particular, we have a lot of patients with chronic obstructive pulmonary disease, and we find in the hospitalization rate the problem related to pneumonia or the pleural effusion. So I think the clinical characteristic of the patient is related to these findings.
Thank you for this reply. I have no additional question. I give back the word to the prorector.
Thank you. The opposition will be continued by Professor Corvino, Professor of Cardiac Surgery, Università Campus Biomedico di Roma.
Thank you very much, distinguished prorector and colleagues. It's a great privilege for me to be here to participate to this important moment of the professional life of the candidate. Dear candidate, I recognize that your thesis is a complete work that required a lot of energy. Among the chapters, I was impressed by the one regarding the aortic annulus stabilization, a new technique to prevent paravalvular leaks after rapid deployment aortic valve implantation, because I think that every technical improvement in surgery is important. As a matter of fact, it is said in the article that the incidence of pacemaker implantation as a postoperative complication in the series you observed is higher than average. I therefore ask if, having made this observation, you authors have already studied what can be improved in technique to reduce this complication, because it seems they are related. You say that simply lower ballooning pressure is enough, but maybe something more could be done.
Distinguished opponent, thank you for the interesting question. I completely agree. We have in either incidence of new pacemaker implantation in our study, we're about 17% of new pacemaker implantation. In our population, I think is related primarily for the clinical history of the patient, because in our population we have 35% of patients demonstrating preoperatively paroxysmal atrial fibrillation, bradyarrhythmias, sinus node disease, and so we know this is related to high risk to new pacemaker implantation after conventional surgical replacement of aortic valve. The other part, we decide to perform a reduction of the atmosphere pressure balloon expanding stent only in the last part of our study, and we performed a 3 atmosphere pressure in respect to the 4.5 or 5 atmosphere expected to the valve size. And the last part of the study, we found no new pacemaker implantation, but we decided to perform this different inflated pressure because of the work of Vogt, the co-worker, which describe the use of Percival prosthesis, not intuitive but similar valve, with a reduction of pulmonary, reduction of pressure of inflating balloon stent, with a reduction in the number of new pacemaker implantations. So we decide to perform the same, and we have this final result in the last part of the study. But we know it's very important recommending long-term follow-up in order to confirm this finding. But the other problem is related with the clinical history and the calcification of the annulus itself.
In practice, you say that the new technique compensates eventually paravalvular leak generated by lower pressure ballooning of the valve.
Yes, the surgical stabilization of the annulus can allow to reduce the paravalvular leak, because performed a strongly match between the stent of the bifrostesis and the annulus itself after the decalcification, the surgical decalcification.
Yes. Another question is, you know, the rapid deployment valves are intended to shorten the aortic cross-clamping. Well, to apply the new technique, does it prolong these times?
Yes, we have noticed 15 and 20 minutes of increase of operating time in terms of cardiopulmonary bypass time and cross-clamping time, but I think it's related with surgeon learning curve, and okay. I think can be maybe better for the future.
Well, I have no other questions. Many thanks for the replies. I'm satisfied, and I truly congratulate the candidate for having continued to increase her skills over the years. I give back the word to distinguished prorector.
Thank you. The opposition will be continued by Professor Mokhtar, Professor of Cardiac Surgery, Maastricht University Medical Center.
Dear candidate, I congratulate you that you're standing here now and succeeded in defending your thesis. I've heard your different answers from the other colleagues, but I still have a question. As you know, surgical aortic valve replacement is the golden standard for aortic stenosis. And now you have made the proposition 4. That's a proposition what's according to the guidelines is a 1A evidence to do TAVI in high-risk older patients. What's your opinion, and with your knowledge, will there be a change in the TAVI part of the for surgery in aortic valve stenosis? Could that be increased? Because nowadays, about 15% of TAVI compasses surgery for aortic stenosis. Can it be a higher number in the future? And what are the prerequisites? And I especially want to elucidate on teamwork.
Distinguished opponent, thank you for this interesting question. I think that with the increasing of age of the population and increasing comorbidities, we have all the day field patients with very important clinical history, and so the novel approach of discussing all the case and among our team is very important, because we have no a complete good treatment for all the patients. It's very important have the new prosthesis benefits in terms of hemodynamics performance, long-term durability, good outcome, together with transcatheter implantation technique in order to treat the patient with a very high surgical risk score. So I think that sutureless prosthesis demonstrated an optimal results in all kinds of patients, with reduction of operating time, but also reduction of the complication, in particular with conduction disorder. But I think nowadays several papers described good results with rapid deployment aortic valve, also in patients with bicuspid valve or endocarditis or poor aortic regurgitation. So I think in this moment we are able to treat all kinds of patients, but the most important point was the good knowledge of the patient with his history, his clinical presentation, and a good study between the use of non-invasive imaging, in particular echocardiography, that we allow to have a precise view of the aortic valve itself, and computed tomography scan can we allow to know the chest and the vascular arches, and so I think all this data we allow to perform the good choice for each patient.
Yeah, thank you. But my questions focuses more on the teamwork. Is there in the team worldwide, or where you're working on, also interventional cardiologists and surgeons, and even, let's say, other interventional specialists? Do you think that's a prerequisite to improve and enhance the quality of TAVI procedures with all the knowledge these people have?
In our hospital, we perform the TAVI procedure together, cardiac surgeon with interventional cardiologist. In case of transcarotid arches, transsubclavian, transcatheter aortic valve implantation, transapical, and transaortic arches. In the case of transfemoral transcatheter aortic valve implantation, usually the interventional cardiologists work alone. but every week we make a long session of our team in which we discussed all the cases and decided the planning for each patient and the team for each patient.
Oh, that's good. I have another question, but that's more a general question for you, being a female heart surgeon. What's your future in cardiac surgery, and do you make contact with the European Association of Cardiac Thoracic Surgery and especially women in cardiac surgery? What's your idea about it?
Thank you for the challenging question. But I think in this moment, the problem is not related to the gender, but is related to the hybrid profile. Because I think in this moment, the most important thing for the cardiac surgeon is the team building with the cardiologist about interventional practice, because we have some skills and we are able to treat all kinds of patients with their related problems after surgery. But the same for the complication after transcatheter aortic valve procedure. But at the same time, invasive cardiologists have too much skills with transcatheter technique. So I decided a few years ago to work together with the cardiologist team. So I work in my hospital in hybrid between cardiac surgeon and cardiology. As it's very difficult work because we have different point of view, and when we discuss the patient, it's very difficult and sometimes understand the point of view of the cardiologist and describe the important view of the surgeon. So I think the future for the cardiac surgeon is improve the collaboration with the cardiologist in order to offer the best treatment in feel difficult clinical presentation of the patient. So I think the effort is to make a good team building for a real art team. This is
Thank you for your answer. Thank you. And I will give back to the pro-rector.
Thank you. Before I give the word again to one of the members of the degree committee, I'd like to ask you one short question. Maybe proposition 7. One of your colleagues can read proposition 7.
Good morning. To perform a good cardiac surgery, you need to know everything about the patient.
Maybe you can explain everything. I can imagine a lot. You like to know many things, but everything.
Distinguished opponent, thank you. I'm very, for me it's very important the knowledge of the patient, of this family, and the idea of the operating procedure. So it's my attitude to make a meeting with the patient, so speaking about the clinical history, but also idea for the treatment and speak with the family, because I think we can perform a good work, but after the surgery, the patient return to the family, and so it's a teamwork with the family. So for me, it's very important a good knowledge in this sense of the whole of the patient.
I can imagine, but again, everything. Everything means very much. Maybe you can explain everything.
I think the clinical problems and laboratory exams, so imaging and so on.
So it's maybe not everything, but you want to know many things.
Many things.
Okay. Yeah. that was a challenge, I think. I think we have left a few seconds and we wait for the beadle to enter the room. Maybe you can start
Very
again.
quick question from an old surgeon, Paleolithic surgeon, I call myself. Mismatch. What do you think? Mismatch between TAVI and the other valve in your thesis?
Very short answer. Very short.
With surgical aortic valve replacement with rapid deployment aortic valve and sutureless, we have no patient positive match, and I think it's related to the subannular fixation of the prosthesis.
Thank you very much.
Okay, Elena Caporali, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Elena Caporali, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the committee has decided to grant you the degree of doctor. Professor Larusso is authorized to confer upon you this academic distinction in accordance with Dutch university custom. And I invite your supervisor to now take the floor.
Please all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest and transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, in present and online, I hereby confer upon you, Dr. Elena Caporali, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will receive this diploma, this certificate, signed by the rector, the secretary, supervisor, and affixed with the official seal of the university.
Thank you.
I think I left, no, but in any case, I know. Okay, I knew what to tell you. Now, dear Dr. Caporali, dear Elena, first of all, it is my great pleasure to be here with you, your friends, your family, and I think it has been such a great pleasure supporting and guiding you through your PhD and research projects in the last years. I still remember when you asked me about the possibility we discussed yesterday and the long discussion we had, trying to explain to you the great efforts, the possible failures, the possible successes, but also, I remember very well we discussed the great satisfaction by reaching such an objective, and I am really sure that now you understand much, much more my words at that time. However, you worked hard, you kept on moving, particularly when you had to deal with difficult tasks, like taking care of the result of an international prospective randomized trial with more than 40, almost 50 worldwide centers, and realizing 2 studies of it. Not really easy. I mean, it was not easy at all. And I know that you coped efficiently and you worked hard with the principal investigators, the steering committee members, with professionalism and determination. And this was exactly mentioned during the meeting before, your determination. And I think this was exactly my admiration about yourself, because you were really determined from day one. And I'm also sorry at the same time that I bothered you so many times regarding the papers and, and also to prepare the presentation of today. And I think that helping you to finalize all the tasks assigned to you, writing the papers, dealing with the failures, dealing with the successes, I think that I really enjoyed, because I saw your very always positive reaction. And I saw also during the time I was trying to give you some advices how to prepare the presentation, how you really accepted without any kind of hesitation. So I think that Beside the Thesis request myself of changing, modifying, changing the color, the timing, and everything, or putting a table or a figure, I think that you appreciate that our was a real teamwork for today. And I think you also understood very well that any challenge, like the one of today, but also the ones you faced during your PhD trajectory, that any challenge must have a proper planning, preparation, and execution. And I hope to have been able to provide you additional advices that I hope that you will use in your future professional and scientific career. The PhD degree is usually a very prestigious objective and achievement, but also usually the start of an academic career, which I hope you will keep on pursuing with our research and collaboration with peers around the world, as you had the opportunity to do for this research project, which you nicely finalized today. I think you will also learn how to cope with difficulties and how to overcome obstacles which are usually encountered in our professional and scientific pathways. And I hope you will remember in the future that discussing and finding the tools and ways to react to failure is the most important thing, besides, of course, celebrating, but not too much, once you achieve successes or recognition because of your work. You have been working in several places, and you had the opportunity to experience teamwork, we said today. I hope that the experience you had during your PhD period and the related work you did will strengthen this perception that you have about the importance of hard team building, and so forth. And you should continue this way. So finally, I would like to congratulate, of course, yourself, but your family, your colleagues, your friends, and particularly your mentor, present today here with us, who was able to show you the way to go. So congratulations again, and I wish you all the best for the future endeavors, which will be along your professional and scientific career.
Dear Dr. Caporali, also on behalf of Maastricht University, I wish to congratulate you with the degree you have acquired. Before closing the ceremony, I will give the floor for a few minutes to first Professor Prinsen.
Dear candidate, young doctor now, congratulations with this achievement. You did very well in the defense. And finally, one maybe little comment in a connection to the question of Dr. Mokhtar. How should your team look like? Maybe consider to include an electrophysiologist, considering all the conduction abnormalities occurring due to TAVI. Thank you.
Thank you. Subsequently, Professor Cassina.
So, thank you very much, Elena. I work with you every day since many years, and I appreciate every day your clinical activity and also your scientific commitment. I have only a few words. I would like to encourage you as young female cardiac surgeon for the future generation, and also to work in this new way and new approaches, minimal invasive approaches for the patient and for new discovery in the medicine. Thank you very much.
Dr. Di Mauro.
Elena, we met many times ago, many years ago, when we were in the board of the Italian Society for Cardiac Surgery, and I appreciate all the time your friendship, your mood, your way to address all the tasks. And today, for me, is a great privilege to be part of this Corona in your doctor defense. And so congratulations from my heart for your achievement, Elena. a very great achievement for you, but you deserved it. So all the best.
Professor Mokhtar.
Congratulations, Dr. Caporali. And I've never met you, but I think there's a bright future for you, especially when you're working in a team and expand the team with more, let's say, specialists in the field of TAVI, and look at your, let's say, female surgeons in the European field who are standing in the front line of also contributing to scientific knowledge in cardiac surgery. Thank you.
With this, I close this academic ceremony.